Dear viewers, today let's look at surgery of the parotid gland. Surgery of the parotid gland is challenging despite the small size of the gland due to the fact that the facial nerve and its branches traverse the gland. Damage to this nerve, as you are aware, results in facial disfiguration and other morbidities. There are three types of tumors that involve the parotid gland. First is primary parotid tumors. Second is metastatic tumors. Third is extensions from regional head and neck malignancy. Based on the plane of which the nerve travels through the gland is divided into superficial and deep lobes. There are three types of parotid resections. First one is the conservative superficial parotidectomy, where all tissue superficial to the nerve and its branches is excised en bloc together with the tumor. This can be done for superficial lesions. This is the least invasive parotid surgery since we no longer justify unscientific resections like enucleation of parotid lesions. Second one is the conservative total parotidectomy. When the tumor extends to the deep lobe, this can be performed. Often due to the position of the facial nerve, it is very difficult to excise both superficial and deep lobes intact. In either above, sometimes it may be necessary to sacrifice a branch or two of the nerve to resect the tumor completely. Third one is radical parotidectomy, which is fairly easy to perform since we completely disregard the presence of the nerve within the gland and excise the entire gland en bloc with the nerve. You can see the cross-section of the parotid gland on this slide. Here, number 1 stands for the superficial parotid, number 2 the deep parotid, number 3 the retromandibular vein and the external carotid artery, number 4 the main trunk of the facial nerve, number 5 the styloid process, number 6 ramus of the mandible, number 7 the mastoid process, and number 8 the lateral wall of the pharynx. Also do not forget the NVA order, which tells you that the nerve is the most superficial structure, then the retromandibular vein, and finally the external carotid artery. The time-honored incision is the modified Blair incision, which is shown here. When raising the anterior flap, care must be taken not to raise the flap beyond the anterior border of the parotid to prevent damage to flimsy terminal branches of the nerve. As we said in our video on how to be a great surgeon, we must tackle the facial nerve head-on. The nerve lies deep in a valley of tissues between the external acoustic meatus and the posterior border of the parotid gland. When we start digging between the cartilaginous part of the ear canal and the posterior border of the parotid, a spiky cartilaginous protrusion appears pointing anteriorly and inferiorly. This tells us to proceed with caution since the nerve can be found approximately 1 cm anteriorly and inferomedially to this pointer. Dissecting the area directly posterior to the pointer takes us to the styloid process, the posterior limit of our dissection. Since the nerve travels just lateral to the lower part of the styloid process. Once the nerve is located, then all that is left is to carefully dissect just over the plane of the nerve in the case of a superficial parotidectomy, and around the nerve and its branches in the case of a conservative total parotidectomy. Sacrificing the nerve or en bloc resection of the gland together with the nerve is carried out only in 3 instances. First being pre or perioperative evidence of involvement of the nerve trunk. Second is in the case of extensive infiltration by a regional tumor. Third is when solitary metastatic lesions of tumors of high malignant potential like melanomas involve the gland. We hope this presentation would be of value to you. Thank you for listening.